You mentioned treatment-resistant schizophrenia, clozapine earlier. What would be the ideal definition, or a more, I guess, applicable definition of treatment-resistant schizophrenia? Traditionally, we've thought about it as non-response to two antipsychotic medications.
I think that's a little bit outdated. Unfortunately, most of the guidelines across the world still suggest this. Again, with hyperdopaminergia as the etiology for probably 3/4 of the patients, if the patient has not responded to a good dopamine blocker, of which there are several, in a reasonable period of time, and I would suggest the time frame for a trial of treatment be not more than 4 to 6 weeks. 8 weeks perhaps would be the most, but most patients will start to respond within 2 weeks, a week to 2 weeks. Not the full response, but you start to see this, and this is true in all research studies of all antipsychotics. You start to see the response early on before it's completed later on at 8, 10, 12 weeks, and even years after. The medicines still have an effect even years after you've started them. So that's straightforward. Patient doesn't respond to an oral medication that's a dopamine blocker, and you're convinced the patient's taking it, then you go to clozapine. There is an issue with a lot of patients, however, and that is the issue of adherence. And this can be truer in the first episode group, who are notoriously known for not taking their medicine or being hard to convince to take the medicine. But this applies also to the multi-episode population as well. So if you're convinced that the patient really has not been taking the medicine, a trial with an injectable long-acting antipsychotic is really necessary. And of course, whenever we say long-acting antipsychotic, the trial is probably on the order of at least 3 to 6 months in order to make sure that there's a stable blood level for that antipsychotic given parenterally. Okay. And then you move on to clozapine if that didn't work, if the patient will take an oral medication, of course.
I understand that recently the TRRIP group, the Treatment Response and Resistance and Psychosis group, sort of came together to come up with a consensus definition of schizophrenia, or treatment-resistant schizophrenia rather. Would that be considered to be the most sort of applicable definition at this point in time?
Yes, I think it's a very good article. I think it's a must-read article for everyone. I think it's a very ambitious article in the sense that not everybody is going to collect enough patients to be able to test out the hypotheses that are described in that work of literature. But the ideas are the good ones, which is to say we have to try and homogenize the groups so we have a more cognitive deficient group here, cognitive deficit group here, a negative symptom group, a more positive symptom group, perhaps a more impulsive symptom group. So if we can find medicines which find a group of people with a more homogeneous set of symptoms, then we can start to try treatments. And also maybe at that point, we'll come up with a little bit more in terms of the biological markers, both in terms of imagery, genetics, and biochemistry, and electrophysiology. And up to now, this has not been the case. It's still pretty elusive, but I think it's the best hope we have.